Welcome to the CAA 2022 webinar series. Today's webinar is CAA 2021 Awards for Excellence Star Award winner, Stroke Pre-Hospital Informed Decision Making using EEG recordings, presented by Wayne Loudon. Thanks for joining us and we hope you enjoy.
Welcome to Council of Ambulance Authorities webinar series. I'm Mojca Bizjak-Mikic and I will be your host today. We're very excited for today's webinar. Not only will you get to hear about a wonderful project that will no doubt change lives of our patients in the future, but we're also thrilled that this project won the 2021 Star Award in the CAA Awards for Excellence. The CAA Awards for Excellence this year celebrates 15 years, and the Star Award gets selected from all category winners. 2022 awards are closing soon, end of April, but you still have a bit of time to put in your submissions. Today's presenter, Wayne Loudon, is a critical care paramedic with Queensland Ambulance Service, and he's also a visiting fellow at Queensland University of Technology. Throughout his career, Wayne has been involved in stroke care. His current research interests include the use of mobile technology for pre-hospital critical care and stroke systems of care. Today he will share with us his award-winning SPIDER project. SPIDER stands for Stroke Pre-Hospital Informed Decision Making using EEG recordings. Thank you so much, Wayne, for your time today to share more detail about your research, the results, and exciting future opportunities for this project. Welcome, Wayne.
I just want to begin by acknowledging the traditional custodians of the land that this study was conducted on, and that I'm now here recording from. That's the Turrbal people. I just want to pay my respects to elders past, present, and emerging. I thank you to Council of Ambulance Authorities for the honour of the award in excellence for our study. It certainly was unexpected, and we're very appreciative of that. Now, the Stroke Pre-Hospital Informed Decision Making using EEG recordings was a study that took quite a couple of years to really develop and get off the ground, and really highlighted to me the importance of us doing these studies, not just from the point of, in this case, stroke, but in terms of pre-hospital and providing a much greater level of care to the patients that we treat. Now, as everyone's well aware, acute stroke does result in significant burden on both patients, the healthcare system, and society as a whole. The vast majority of strokes, as we all know, are ischemic strokes, and that's obviously where a lot of our treatments lie, acute treatments lie, in terms of both thrombolysis, clot retrieval, if it's a large vessel stroke. Now, what we know is those patients that do have a large vessel stroke, their mortality is much higher, their morbidity is much higher. They certainly don't do as well. They also typically present with much more obvious symptomology. Having said that, we're still limited in clinical assessment alone of these patients, and obviously imaging is really important before interventions are started. What we know is that if we can identify not just those patients having true stroke, but obviously those patients harboring a large vessel occlusion, if we can identify them earlier and make some decisions about the destination, we can really influence the trajectory of care. In this work I did as part of my PhD, we looked at sort of the symptomology that paramedics were identifying, and then their accuracy in terms of their end diagnosis, whether it was a stroke or wasn't a stroke. Now, in those patients where it was true positive, paramedics were correct. Obviously, it's not overly unsurprising to see that those patients that had things like hemiplegias, speech abnormalities, facial droop, and such, were often picked up. Now, that could be a function of these being the most obvious symptoms, and typically, especially when they're in a constellation of symptoms, more likely to be stroke, and therefore it's not surprising that both at the point of 000 call, as well as at paramedic assessment, if these things were present, then typically we were pretty good at getting it right. What we weren't so good at is if the patients had some symptomology that was usually consistent with your posterior circulation strokes, for example, your ataxias, your vertigos, and if these were present or your visual disturbance, if these were present, then the chance of getting a false negative diagnosis was much higher. So there's still a role, albeit that this is a very small group of stroke patients, and thankfully we are pretty good at identifying those with sort of an inclusion to the MCA. They still have a significant burden of morbidity and mortality on them. So being able to identify them is obviously our end game. But clinical assessments are limited. It doesn't matter who's performing them or how in depth they are. There's always going to be a limit to what can be done through clinical assessment alone. Now, many of the services across the country obviously have initiated the use of various large vessel occlusive stroke tools, and the aim here is basically the more severe the stroke syndrome, the more likely it's involving more brain tissue, and therefore, by extension of that, involving a large vessel. Now, as you'll see in terms of their performance, they're all, you know, fairly similar. It'll depend on obviously the population and the training involved for those paramedics. Here in Queensland, we elected to move to the NIHSS 8 or the Hunter 8, if you like, if you're familiar with that in New South Wales. And the reason being for that is its performance was comparable to things like the ACFAS and the RACE score, but it was a similar language that we could use across both, you know, in-hospital staff who are aware of the NIHSS, albeit not everyone is, and obviously our colleagues across the border in New South Wales. It made sense to us to do that. Now, obviously, it involves a little bit more maths, but through the wonders of technology, this can be performed quite well. However, regardless of which tool we use, there's going to be limitations placed on us being able to identify those patients that might be eligible for care. So technology is still going to play a part. As many people will be aware, the mobile stroke units have been rolled out increasingly across the world in various metropolitan areas, some rural areas as well. And everyone will be aware there's some controversy around their cost and the health economics. However, the studies have been done and have been published, and they have found that there is obviously benefit in terms of streamlining this and making the benefit even greater, the cost benefit even greater. There's ongoing work, and the Australian Stroke Alliance is certainly looking into other mobile imaging devices that will ultimately result in us seeing those pre-hospitally in the next, you know, in the coming years, which is really promising. What's also worth noting, and sometimes I think gets lost in the discussion around a mobile stroke unit, is that it's not just about the CT scan that's in the back. Obviously, there's still the benefit of some real expertise in there, both through paramedics, nurse practitioners, radiographers, and whether on scene or by telemedicine consult and neurologist, stroke expert neurologist. And that certainly makes a difference to stroke care, not just in terms of the delivery of thrombolysis, for example, but certainly from a triage point of view, delivery of other interventions, whether it be blood pressure control or reversal anticoagulants. So there are other benefits, and certainly I think with any health economics argument, if we can, you know, streamline that and certainly improve the cost benefit of it, then it will be far more available across the country. Now, in terms of stroke care, it's never just isolated to one thing. It's not just about technology. It's also about the systems of care, how we integrate with them, the education systems, the clinical governance around all of this. But also what you see is the more paramedics are exposed to assessing patients and picking up those that have had a stroke, the clinical exposure really does play a part in their ability to identify them. Decision support tools are sort of rolled on top. They're there just to support the clinician in making whatever decision it is. And in our case, it'll be a bypass decision, for example, instead of going to the nearest facility, maybe taking the patient with a more severe syndrome down to a facility that is able to do clot retrieval. Now, that doesn't mean that when you get down there, they're necessarily eligible for that. There's a whole set of things involved in imaging assessment that are required before they'll be eligible. But we're at least starting that process off early in their disease process. Right, so in terms of what is QEEG or EEG? So quantitative electroencephalography looks at the activity of a large group of synchronized neurons. Now, everyone would have seen EEG and been very confused by what it all means. Lots of wiggly lines, hard to interpret, not as easy to sort of see patterns as you would say in an ECG. But put very, very, very simply, the alpha waves, or those very high frequency waves, are quite normal. That's sort of what you want to see in healthy brain tissue. As the ischemia increases, then obviously there's a slowdown, there's a widening, not dissimilar, I suppose, to where you see in terms of myocardial cells as they begin to become ischemic and the ECG starts to widen and slow down. Then what we need to see is, well, obviously we can't train every clinician to read an EEG. It's very hard to do that. So quantitative measures provide an opportunity where using some computing power, it's able to spit out essentially a number not dissimilar to, say, an SpO2 and entitled CO2, blood pressure, for example, and then understanding what that number means and where it's good or not, similar to knowing whether a BSL above or below 4, for example, is a good thing. So this is what they found. So they did some studies in hospital before we sort of did pre-hospital stuff, and it was purely by coincidence that this, I suppose, came to be, because the study had been conducted by Professor Wong and Dr. Finnegan in hospital, looking at whether EEG data could identify the presence of ischemia before they realised there might be an application of pre-hospital. So it was just purely because Dr. Wong ended up being my PhD supervisor that I think he had a bit of an epiphany and realised, hang on, maybe the pre-hospital stroke area has a role for this, what we've been doing here. You can see as a patient that was in one of the early studies, and you can see the arrows that point to what would be a delta wave and alpha wave. And then what they've done there, they looked at the ratio between the alpha power and the delta power in a patient who had reasonably severe stroke syndrome. And you can see with that topographical mapping, that heat mapping, that it can really localize where the spread of that ischemia across the scalp on this patient. Obviously, by extension, if there's a large amount of brain tissue involved, then potentially there's a large vessel that's involved. So they went on further and sort of looked at across from healthy controls, similar ages and genders, those with healthy versus mild and severe stroke syndromes. And what they see that in this particular case, the delta alpha ratio did increase as the ischemia became more severe or more widespread. And what they were able to work out is that a number of less than 3.7 was 100% specific for the absence of ischemic stroke, and that greater than 3.7 was 100% sensitive for the presence of ischemic stroke. So it certainly had some promising results that we wanted to explore further. And obviously, we weren't just going to look at that delta alpha ratio. We're going to go beyond that into other potential quantitative measures that we could pull out of the EEG. This study was quite novel. To my knowledge, it's the first time something like this has been done, certainly in Queensland. So there's a lot of learning involved in the early stages to figure out the governance processes, and often what we ran into is there wasn't certainty about how we could deliver this program. So we got a lot of support from the research unit from Queensland Ambulance in navigating that. And so it took about 2 years from inception to when we ultimately delivered the project, just by sheer amount of work that had to go into it. And what we were trying to do is trying to see if EEG could discriminate those that are a mimic versus true ischemic or true stroke versus those that might have a stroke, but whether it's a large vessel occlusion or not. And initially what we're looking at is comparing it with the performance of what we used back then, which was the Melbourne Ambulance Stroke Screen. Now, obviously, subsequently we've moved to the NIHSS 8. But what we were trying to achieve is be able to say, are we better with an EEG, or does it not really add anything on top of the clinical assessment? So we isolated this to the Metro North region of Brisbane, so the Royal Brisbane and Women's catchment. So a population of around a bit over 200,000 with density of about 140 per kilometre squared, which is quite not anywhere near as dense as Melbourne. So in terms, it was really going to be challenging for us to recruit a reasonable amount of time frame for the study, the patients who we're looking at. So what was very generous of Queensland Ambulance is they were able to provide us with in-kind support that involved a response unit, and ultimately myself as a study paramedic to proceed out in that area to anything that was a suspected stroke, not just to obviously do the research study, but it was an opportunity to really put a focus on stroke and some education to our paramedics. The research was really important with this research team, and what I really learned from it is the importance of that multidisciplinary approach. So we had everything from obviously stroke neurologists, neuroscientists, to a real expert in pre-hospital research, Professor Tippett, as many of you be involved in. That sort of guided us through both the governance process, delivery of a research project in the pre-hospital setting, which is challenging, and anyone that's been involved in that can appreciate that, but also really understand the role that the neuroscience side of things and the neurology side of things had. So it was a good team that we put together. Now, in terms of where the name came from, it was an unusual name. But initially, when we started looking at this project, we were really keen to have something really functional in terms of the device. So we started looking at this device in terms to use. Ultimately, due to TGA approvals and stuff, it's not really something that we could use. However, we had already developed the name, because obviously it looks very much like a very large black spider. And then the acronym sort of grew from there. But in the future, we can imagine that devices not dissimilar to this could be used, and therefore don't require a significant amount of understanding about application and locations for application of electrodes. The device we did ultimately use was this one over here. It's about probably a little bit smaller than a tablet, not overly heavy. It was a very simple device. It was essentially turn on, press play, and it records. There was no live interpretation, so there's no need for anything that, although it can be connected to your laptop so you can see the live EEG, there's no need for that. We would do the recording and then ultimately download it at a later date. So all patients that were potential candidates would be recruited, and I'll talk through how we identified those patients a little bit. But we would attach some EEGs to some electrodes to their scalp, and they were just gel electrodes, not similar to the ECG electrodes. We didn't want to necessarily put too many electrodes on, because there's no point doing a study where that requires you to measure and place a lot of electrodes. Obviously, that delays care as one issue, but it's not really going to be something that's going to be possible going forward in a true clinical sense. So we kept to very global measures, so it only required us to have ultimately 6 electrodes. These are the main electrodes that are shown here on Dr. Finnegan. And then we had placed another 2, which were an earth and a reference electrode sort of between the forehead ones there. One had trained me on applying these. I found that it was very easy to do within about 2 minutes, fairly reliable read, and it was certainly readable in the post hoc analysis. The EEG would then be recorded throughout transport to the Royal Brisbane and Women's Hospital, and then prior to entry into hospital would remove that. Now, during all of this, all the standard of care was still delivered, pre-notification still occurred. There was no real delay. If I had to be applying electrodes, the paramedics would be doing pre-notification, for example, or delivering of any treatments that may have been required. Because we were essentially placing a new resource out into the region, I recognised that we really needed to communicate to our staff what this was and what it meant, to prevent any confusion or any mistruths about what we were trying to do. I didn't want paramedics to think that we were going to be delaying care, that we'd be changing care just on a whim without any real proof of what we were doing. I developed these flyers, and what they did is they all had roughly the same information, but they were really targeted at different groups. So we were dependent on the clinical deployment supervisors in a sense to identify any cases early on that maybe didn't get picked up by the AMPDS program. And they were able to obviously either attach to me directly, or they had my phone number, they could ring me and discuss the case, and I would make a judgment of whether that potentially could be a stroke and therefore proceed out. The emergency medical dispatchers, they play a very critical role. They had this on their desk next to them so that they could refer to any stage if they weren't sure on what to do with me as a resource, and it worked quite effectively. We also wanted paramedics to understand, although they didn't have to change anything that they did, they didn't have to, we weren't asking them to get on scene and then request me later, because that would result in a delayed care. But it was important that they knew why I was turning up, and certainly prevent confusion, because obviously at that time having a critical care paramedic turn up at a stroke would be highly unusual. But it was very well received, and they were generally very receptive to me attending, and anecdotally years later I've still seen the benefits of people who I did attend on scene, and we had a good discussion, as well as obviously delivering the project, but a good discussion around stroke and some on-site learning, and that really was beneficial, so from a collateral benefit sort of view. The data analysis we're going to do is essentially build some models to determine which of those EEG measures, those quantitative measures, could be used, and maybe in conjunction with some clinical assessments as well, to build a model to sort of be able to give us a reliable indicator of whether a stroke was present or whether it's large vessel or not. Obviously, any study requires ethics consideration. We really had to think carefully about making sure this wasn't going to delay care, that this wasn't going to change care in any way, and the patients weren't disadvantaged in any way. And being an emergency situation, we also didn't want to have to spend an extensive time, which would be inappropriate, doing any sort of consenting procedure. So we got a waiver of consent at that initial stage, and then if required, would present to the patients later for a consent to continue. We had a lot of support for this. So obviously we got initial funding from the Royal Brisbane Women's Foundation. They were fantastic and funded various rounds of funding after that. That allowed us to have the neuroscientists on staff, albeit only for a few hours every week, to do the data analysis. That's certainly not something that I myself or even Professor Wong was able to do. So that was fantastic. The equipment we got on loan from the University of Queensland. You're talking in the region of $20,000-$30,000 for one of these devices. So it's quite a significant benefit that we had. And then a significant amount of support from Queensland Ambulance Service. They came out and obviously allowed me in my employment to deliver the project, as well as provided me a response resource. And I took it upon myself to make sure I was giving them, as an organisation, as a public organisation, value for money. So not just delivering the project, but delivering education throughout it, and certainly delivered a lot of pamphlets, CPD events during that time, as well as on-scene training for paramedics. And in the meantime, at times when I wasn't necessarily attending to a stroke patient, I would also be available to be dispatched as a critical care resource, and attended quite a significant number of jobs as well. That didn't impact on the study, and to my knowledge, there were no stroke patients that were missed in terms of recruitment during that time while I delivered that. And I was very comfortable with that as a clinician, and I think that's the right thing to do for the population. So it really worked out having that as a resource. In terms of the criteria, any patient that was screened as a potential stroke through AMPDS system, or the CDS or the EMD might highlight and say, hey, I think this might be a stroke. And also on top of that, I had access to our IRM platform, which on a tablet allows me to see all active cases in the region. And there I was able to then get all the information off those and pick up any ones that weren't stroke. And there were a few that I picked up. That was the case. I was then attached. The paramedic did assess a patient and thought, and it hadn't initially been flagged as a potential stroke. They did have the option to highlight it and request my attachment. However, if there was any suggestion that would then delay care, then I'd either not attend, just meet them in hospital, have a discussion about the case. But we didn't have any issues with that because we communicated really well to them at the start about not delaying care in any way. We didn't really run into any issues there. This was only within the Royal Brisbane Women's catchment, and then obviously the patients submitted. We obviously didn't include children, some different etiologies, different treatment pathways there. Pregnancy and previous craniotomies, there was some initial concerns that there might be some issues in terms of the EEG recordings. I think subsequently it was decided that probably wouldn't have affected anything, but ultimately we never came across any patients with those present with either pregnancy or previous craniotomy, so it didn't affect it in any way. So the recruitment strategy, as I said, at the point of the 000 cord, would be coded as a stroke patient or not, or via the IRM platform or the CDS, and I'd be attached. At the same time, though, standard response still occurred, nothing changed there. They'd proceed out. I'd either sometimes beat them, but often arrive shortly after them. We'd perform our assessment. We'd decide if this was or wasn't a stroke. If it was a stroke, we'd obviously refer it to the hospital, pre-notify the hospital, deliver any interventions that are required, extrications, so forth. And then once in the ambulance, apply those EEG electrodes and begin recording. And then I would proceed with the crew to the hospital. So during the study period of about 6 months, we recruited a total of 54 patients. About 20 of those were ischemic stroke with non-large vessel, about 12 were large vessel. And then, we had about 3 intracerebral hemorrhages and 18 mimics. We did lose 1 patient to follow up. However, having treated all these patients, I am aware that patient was an intracerebral hemorrhage patient in the end. So these are sort of the measures we're looking at. So if you're looking at the axis there, the EEG abnormality marker, you can see as it increases, and each diamond here is an individual case. So this particular marker, if in a patient who had a confirmed large vessel occlusion, you can see that the abnormality marker was quite elevated. And then with those patients who had ischemic strokes but not in a large vessel, the marker was still quite elevated versus those with mimic or TIA resolving symptoms. Their EEG marker of ischemia is quite low. This graph just illustrates two patients, similar presentations in terms of hemiplegia. The one on the left ultimately was thrombolized and had quite a severe syndrome. The one on the right, although presenting with quite similar symptomology, it did resolve during transport, or mostly resolved, and ultimately their EEG abnormality marker was much lower than that patient that obviously didn't have resolution of those symptoms, which is, as you'd expect, but a good indicator that the marker is certainly doing its job. Here we have an example of two patients, both confirmed ischemic stroke. One had a M1 segment of the left MCA involvement, and the patient on the right, it was in the M2 segment. The relevance of this is in terms of those patients that are eligible for clot retrieval. So the patient on the left would most certainly, obviously there's other considerations, a lot of other imaging has to go on, but it certainly indicates that even in the presence of similar symptomology across the two patients, we might be able to identify those that have an occlusion to a salvageable vessel. All right, well, thank you very much for this opportunity. It was a great project. What got out as a collateral to this was the importance of paramedics being involved in sort of clinical research, but the collaborative approach that we have to do. This is not something that's necessarily done in isolation amongst paramedics, but certainly done with a multidisciplinary group of people. And we also hopefully you sort of showed paramedics that if they come up with these projects, they go through all the right governance sense. There really is the opportunity that the services will support them in delivering this sort of a project. And I really hope that through the attention that this project has received, that hopefully other projects will be developed, not just obviously in Queensland, but across the country. I think we've all got great things to offer, and slightly varying population groups, geographical challenges, even just outside of stroke, and certainly I think we'll see a lot of changes in the pre-hospital arena in terms of imaging and technologies that assist our clinicians to make some decisions. So it's really exciting, and I look forward to questions if there are any.
Hi, Wayne. Thank you so much for that. That was really wonderful, really just fascinating research, if you ask me. Where are you at now?
We've sort of extended the project a little bit because while we were delivering this project, we sort of were looking at the trauma space, just given some case that we attended incidentally during that time. And we're actually in the next few months going to do a very similar study, but looking at traumatic brain injury. So the stroke side of things will continue on, and in time we'll develop a much larger study. And as you can appreciate, the 2 years to put together a study that recruited 55 people, a larger study is going to take a number more years to really get off the ground. But in the interim, we're going to sort of see if it extends out into these other patient cohorts.
Wonderful. So you're continuing the stroke study, just ticking away at the time, or is it paused and then you'll do a bigger one?
Yeah, so we'll continue working on it in the background and developing it, and obviously publishing and all that from this stage of the study. It was always going to be a long-term thing. It's sort of a slow burn with this sort of work, but on the side we're sort of seeing whether it has a role in other cohorts as well.
Perfect. And I hear that you got a grant as well?
Yeah, so we were lucky enough the Emergency Medicine Foundation's funded us for the traumatic brain injury study to deliver that in the next couple of years.
Perfect. I've got a question from Tim, and he says, slightly off topic, but what's your opinion on lysis for stroke? Does the benefits outweigh the risk, and should there be a difference between metropolitan, rural, and remote?
This always comes up. So thrombolysis always... It's somewhat controversial, but depending where you go in the world, less controversial. There's certainly in Europe, they have no issue with it. And there's not really any argument. It's certainly in Australia and the US, and due to some of the initial studies, there is a belief that it doesn't work. Now, thrombolysis is not anywhere near as much of the has much of the effect that we see with thrombolysis in STEMI, for example. But certainly they've done the studies, they've re-looked at the data. There is a benefit. Yes, it's not as marked as we see with STEMI, but there's absolutely a benefit. It's been looked at multiple times. Yes, there are some cohorts where if you thrombolize them, they will get worse. It's probably more about patient selection. But any stroke clinician that's involved in those or has looked in depth at those studies, they don't have any real issue with the thrombolysis. It gets a lot of attention, especially with the mobile stroke unit. There's a lot of a focus on, well, it's to deliver thrombolysis. That's obviously one part of what they do. But as I said, I mean, the studies, the meta-analyses, they've looked at it and they're comfortable that it does have a role to play.
Yeah, perfect. Now you mentioned the project was really a combination of multidisciplinary sort of team. How did that work? What were the great stuff, bad stuff? Any advice for people listening?
It's. I think networking is really important, and it sort of came, as I said in the presentation. It was all coincidental in a sense because it was my PhD supervisor who just incidentally done this other stuff. That's often how this all works. But it's certainly, these projects are not something that can be delivered by, a neurologist is not going to be able to figure out how to translate this into a pre-hospital environment. A neuroscientist is not going to be able to do that. I'm not going to be able to figure out how an EEG works because that's not my area of expertise. So you need those groups. And what's important is not underestimating the level of governance. It's all very well having a great idea, but often it's the governance and all the stuff behind the scenes. So I got a huge amount of support in that regard from our research group, Professor Bosley, who runs it, and you just can't deliver these projects as an individual. So you really have to do that networking. It does help if you all get along. Obviously, there's always interpersonal challenges, but I can say we never had any of those, so it's fine.
Stuart's asking, in terms of the remote logistics in Queensland and where the study was performed, how far, I guess, from distance was from hospitals, and sort of what can be done? Like what would be the distances that you can use this in?
Well, the further you get out, and it's not just obviously with this particular technology, any technology, the further out, especially in Queens, the further out you go, the longer it's, even in a perfect system, just the geographics of moving a patient from a remote area into where they need care is going to be challenging. There's inherent time delays in that. So theoretically, the earliest you can possibly identify these patients, the earliest you activate the system, the earlier they're going to get into that care. Now, there's parts of Queensland currently, like for example, that you could have a very severe stroke. It could be identified right then. The system could work perfectly, and you just won't get them down there in a time to necessarily. I mean, clot retrieval, you have up to 24 hours if you have good collateral and good penumbra. But there's a lot of patients that won't be able to access just by virtue of where they live. So the challenge is being to get the systems perfect, identify them very early, and then and hopefully that's enough to get these patients the care that they deserve.
Yeah. And your study you said that was really southeast corner of Queensland, but then quite well, it wasn't sort of.
Yeah, it was very much just within the Royal Brisbane, and that's for a couple of reasons. Obviously, that's where I work, where Professor Wong works. So in terms of running the study, it was a lot easier, but also it comes down to funding. If you're trying to fund a large area, recruit a larger number of participants, the funding adds up very quickly, and so that sort of limited us a little bit. In the future study that we plan to roll out, it will be obviously not just in one area, possibly even be interstate to sort of capture more patients, more participants.
And you said, obviously, you went out with a whole bunch of information and pamphlets and that to QAS staff members and paramedics on ground to be aware of the study. You said there was quite a bit of learning in that. How was the feedback from them? Were they excited? Yeah, we're doing another thing, or
I was pleasantly surprised because I was expecting a bit of not resistance, but certainly not as much interest as we ended up having. So it turned out that staff were really, really keen to be involved in this because for so long, I think if you had a stroke, there was almost, call it an apathy if you like, but there wasn't really a lot that could be done in an acute sense for someone that suffered a stroke. And so for our paramedics, when they saw that at least we were doing some work that might change the situation, they were really keen to help and learn. And that's continued on since that study. So the collateral of the study really was that, there's something that we can do, there's something that we're trying to do, and how can I help that? So it was very well supported and very well received by staff.
That's wonderful to hear, because there's obviously a lot of work going to be happening in the future in this space. So with the Australian Stroke Alliance and, CAA being a part of that one. So that's great to see that on ground. People are really interested in this topic and how to do bits and pieces. Tim's asking, out of the cases that you attended, were there many patients not picked up using the priority dispatch code, so MPDS?
Look, those the MPDS is known to not necessarily be overly accurate. I think off the top of my head, and I could be corrected, but it's around the 50% marks. It's almost a toss of a coin. Pretty much the way it goes is if you have very clear stroke symptoms that the caller recognizes a potential stroke, and then it fits with obviously the MPDS criteria, then yeah, it's probably going to get picked up. But it's challenging, I think, with any sort of system like that, because you're really reliant on the caller knowing what they're seeing. So often if you've got some weird symptomology, or it's just the patient's just not right, that's obviously not going to get picked up by MPDS, but it may still be a stroke. So yeah, it's a bit of a toss-up, and that's why we use that iRoam platform and had a clinician in the room to pick the ones that MPDS as a system just isn't going to pick up. And there's been multiple studies to try and improve on that. It's just really hard to do. So we had those multiple layers, and to be completely honest, I'm fairly confident there would have been very few stroke presentations that we would have missed. Certainly classic, if you like, presentations with hemiplegia. So yeah, I think having MPDS and a clinician involved, sort of layered on top of that, which we do and have had for a number of years, certainly helps.
Any flow-on effect from the study into the comm centers and their teams there? I guess more awareness around it. Anything like that? That was
there would have been. So as I said, every dispatcher in that room had that little flyer that sort of explained the study. And I think invariably, whenever you put focus on something, there's a sort of a transient effect where people think it's forefront in their mind. Whether that's sustained, I mean, I think they've done lots of studies, and there's definitely more than enough evidence that says really educating EMDs about. I'm sure it's not just unique to stroke, but any condition is of benefit. Whether that's then sustained, obviously there's all staff movements and movements in and out of the organisation that go on. So it sort of has to be repeated and ongoing. But the evidence does show that certainly giving that bit of education does improve on the performance of, say, MPDS, for example.
Yeah, perfect. So Zayla's asking your thoughts on telestroke models that are in use. So I know Vic has it in New South Wales. Your thoughts?
Look, telestroke, there's a massive amount of work going on, once again, within the Australian Stroke Alliance. They're certainly doing some, and they're looking at a national platform. Often the barriers to telestroke or to any telemedicine platform is, well, who's going to be available to do it, and sometimes it can be resourcing. So, in terms of, how many stroke specialists are there available in any given state to answer the call 24 hours a day, 7 days a week, and those are often the challenges. So, the benefit of technology now means that you don't necessarily need to be in Queensland to answer a Queensland call. And so I think telestroke, it absolutely is going to have a future, and they're working on that now, and it's going to come. And Victoria's got a very successful program. It's been rolled into New South Wales, and I imagine there's work. I'm not involved in any of that work, but it'll happen. There's no two ways about it.
Thank you so much. That was really wonderful. Thank you for the time. And like I said, it's wonderful to really have pinpoint on Star Award winners, and we were very lucky, and thank you for taking the time to present to us. So
thank you.
I'll let you go. Have a wonderful day, and I'll say if anyone else has any questions maybe for you, we can facilitate that through CAA. So anyone that's still on the line, just connect with us, and we'll pass them on to you. Thanks, Wayne.
Excellent. Thank you very much.
Thank you. Thank you everyone so much for joining us today. The CAA webinar series continues. We've got a couple more exciting ones coming out this year. So at any point in time, just jump on our website to have a look at what the next topics are. We've got a sustainability one coming up. We've got aeromedical, mental health later in the year, cardiac arrest. So lots and lots of different topics, lots of different wonderful presenters as well. And also I'll take the opportunity to invite you all to the CAA Congress. We're finally, after 2 years of not being able to have a live event, having our CAA Congress happening in August this year. So we're in Sydney from the 11th to the 13th of August, and we would absolutely love to see you there. There'll be more stuff on stroke. We've got a concurrent session on stroke, and we've got wonderful presenters from the Australian Stroke Alliance presenting in the main program as well on sort of what they're doing and what the future plans are there as well. So hopefully see you there, and keep an eye out on our next webinar and join us for that one as well. Thank you so much and have a lovely day.
Thank you for attending the CAA 2021 Awards for Excellence Star Award winner, Stroke Pre-Hospital Informed Decision Making Using EEG Recordings webinar. Join us for our next webinar on Tuesday the 31st of May for Infection Prevention and Control supported by RAP. You can also view all of our upcoming webinars by visiting www.caa.net.au/webinars. Also be sure to follow us on social media to keep up to date. Twitter @CAA Australasia, Facebook and LinkedIn the Council of Ambulance Authorities Australasia. Thanks for joining us, and we look forward to seeing you again next time.